Thank you so much to the organizers for inviting me back. I'm glad to be with you and happy to share the talk today on an update on COVID-19 epidemiology and management strategies. I'd like to begin by pointing out a few things that I think are familiar to everyone, but nonetheless merit some discussion. So the first, of course, is that the pandemic is global. We have had nearly 50 million reported cases around the world, with over 1,200,000 deaths. I think the scale of the challenge and the tragedy needs repeating, as it really is a remarkable and difficult time for so many. As the pandemic is global, it is also hyperlocal. In this figure, in which we can see the risk levels by county within the United States, we observe that there are some counties where the risk level is lowest, neighboring other counties where the risk level is highest. This underscores, I think, another important point, that the extent of disease in each location and the trajectory of the pandemic is influenced by several factors. These include when the disease was introduced into a community, the nature of interactions within the community that allow for its spread, and the decision-making both individually and at the municipal jurisdictional level on what types of interventions to use to try to slow spread. This includes masking, social distancing, and of course the impact of testing, tracing, isolating cases, and quarantining their contacts. All of these are tools that can very much influence the local trajectory, and I think helps explain why we see such variation in the nature of even hyperlocal spread. Another key point to underscore is how the pandemic has revealed the systemic racism and its impact, with horrific racial and ethnic disparities in the mortality associated from COVID-19. Here we have a figure showing the cumulative COVID-19 mortality rates by race and ethnicity from the US, where we see that Black and Indigenous populations have suffered the highest mortality rates, whereas white and Asian populations have had the lowest. Again, underscoring that even as we deal with the pandemic, there are other underlying issues of great magnitude that will take even longer to deal with. Now, returning to this idea of local spread, I wanted to share with you some work we published this summer that gets at this question, and I think, again, underscores some of the things that I was just mentioning. In this paper, we collaborated with a number of colleagues in New York City at several different hospitals. New York City had instituted universal screening of pregnant women who were being admitted to labor and delivery wards using PCR tests to identify those who were infected with SARS-CoV-2. This allows us to then estimate the neighborhood prevalence of SARS-CoV-2 based on these pregnant women populations. What we see in the left is our estimates of this prevalence by borough. And we see huge variation, low levels in Manhattan, higher levels in other boroughs and other subsections of boroughs, including South Queens, where there was the highest. We were interested in why there was such a variation in prevalence. And one of the hypotheses we had was that this has to do with who is able to actually stay at home and who, because of employment or other reasons, had to maintain some type of movement. So we used mobility data gathered from cell phones using the Facebook platform for millions of individuals in New York City. And we were able to assess the percent decline in commuting associated movements as represented in this figure. What we saw was an almost perfect correlation. Those individuals who were able to reduce their commuting movements had the lowest prevalence. So this, again, refers to places like Manhattan, whereas those individuals who had to continue working or had other kind of commuting associated movements, those individuals of those communities saw the highest levels of COVID-19. Again, indicating we believe that the movement or ability to support individuals staying at home, these kinds of decisions, both at the individual and really at the jurisdictional levels, the municipal levels, can very much influence the trajectories locally and overall for the pandemic. So when I last participated in this series about 6 months ago, we left off with a few different discussion points. One of them has to do with the choices that countries and communities were making about how to handle the pandemic. Some places were aiming to crush the curve using a combination of lockdown, masking, and extensive testing, tracing, and isolation and quarantine. This goal was to really try to eliminate local transmission as much as possible, the process that would then be maintained through regular surveillance, and await vaccine or therapeutic that they could then distribute to the population. Other locations aim to use lockdowns to flatten the curve. This is a phrase we're all familiar with from the spring, where the notion was that the rise in cases from COVID-19 would be so high as to threaten the infrastructure of our healthcare system, and we needed to reduce that number. That would also give us time to develop these vaccines and therapeutics and help reduce the infection fatality rate and the overall number of cases. So here the idea was just to use lockdowns and slow transmission. We also had questions on what would happen in the summer and fall. What is the extent of seasonality of transmission for SARS-CoV-2? So I'd like to address some of these points here. So in our paper in Science back in the spring, we evaluated this question of seasonality by taking the example of the other human coronaviruses. In here, we looked at HKU1 and OC43 using surveillance data from the United States. These two beta coronaviruses cause common cold type symptoms in people. And what we saw was that, as you can see in these figures, there really does seem to be a seasonal trend with higher numbers in the winter and lower numbers in the summers. Whether this is due to a biological phenomenon or a social phenomenon, it's hard to say, of course, from these data, but it does at least suggest that there's increased transmissibility one way or another of coronaviruses in the winter as compared to the summer. So in this paper as well, we started to investigate what's the impact of different types of social distancing interventions. In this figure, we plot what we observe for the prevalence as well as critical cases on the y-axis, time on the x-axis. And we look at what would happen in the case of no intervention. That's in the solid line. The dotted line reflects the critical cases offset by a few weeks. As we know, there's a delay. And we looked at the impact of social distancing interventions that are 2 weeks, 4 weeks, 8 weeks, 20 weeks, and indefinite, where the distancing interventions would have varying effectiveness in reducing interactions. So the 60% reduction in R0 or the effective reproductive number, basically the success level achieved in Wuhan when there was a lockdown after the first cases of SARS-CoV-2 infection. The main point I want to make here is that with the successful social distancing interventions of varying lengths, what you basically do by flattening or crushing the curve here is maintain a population of susceptible individuals. When there then is opportunity for the virus to continue to transmit among these susceptible individuals, we will see, again, a peak in cases. And as there is in these models seasonality, the delay basically with lower transmission in the summer and higher transmission in the fall and winter will result in the peaks being pushed out to the fall. So again, so long as there are enough susceptible individuals to maintain transmission and opportunities for transmission from infectious to susceptible individuals, we will see spread. And in this case, the effect of these lockdowns is to just push it out to the fall. But we anticipated that just as there was an impulse to flatten the curve to try to maintain the infrastructure of our healthcare system, we would see the same thing happen again with this repeat spike in cases. And that led to our anticipating that we would see cycles of lockdown, so going up and down in response to peaks in cases. Okay, so what has happened? Again, these were projections of some scenarios that we evaluated in the paper. And here I'd like to point out a couple of examples from what we've been seeing now that we are into the fall. So this is data from the United Kingdom. We see there was an initial spike in cases. There was a lockdown leading to reduction in cases. And apparent decreased transmission over the summer. Then individuals in the summer started to interact more, go on vacation, and so on. And that has led to, or is an apparent increase or a clear increase in the number of cases in the UK. And now we have another lockdown in the United Kingdom. Similar kind of pattern is observed in Israel. So again, a spring rise in cases with a lockdown here, and then basically removal of the social distancing interventions leading to increased cases, and another lockdown in Israel, which has quite successfully reduced cases there again too. This is what Kai Kupferschmidt, a journalist working for the journal Science, describes as a strategy of reduce, relax, and repeat. So reduce using lockdowns, relax these social distancing interventions, and then we'll see a rise in cases. And so we have to repeat the same kind of intervention. Again, this idea of cyclic lockdowns or other types of interventions. In the meantime, other countries have that aim to crush the curve have successfully done so. So we know, of course, that the first cases of COVID-19 described in China, but from reported data from China, we see basically that their efforts at surveillance and distancing have been successful in maintaining basically no spikes in cases. There have been just little tiny blips in Vietnam, but again, there very little in the way of transmission of SARS-CoV-2 in the community, and very few deaths reported. Similar numbers in Taiwan, South Korea, and Australia, where again, all of these have used some combination of extensive testing to identify cases, isolate them, find their contacts, quarantine them, and then as well using social distancing, masking, and other types of non-pharmaceutical interventions to really keep transmission down. Okay, so in the US, we've seen tremendous increases in cases as we are heading into the winter. And this, of course, is very concerning with this level of disease already circulating and the possibility of increased transmission now that there is less opportunity to interact in outside, to interact outside as compared to increased interactions inside, given the changes in weather. There's quite a bit of concern for the threat to, again, the threat to our healthcare infrastructure, similar to what we were worried about in the spring. So what do we do? Well, as we've seen in the UK and elsewhere in Europe, repeated lockdowns. We have to continue with masking, distancing, and again, the importance of testing cannot be overstated, together with supported isolation and quarantines, trying to figure out how to deploy these tools to really, again, effectively reduce the numbers of cases, as these cases will certainly be followed by hospitalizations and then deaths as well. At the same time, we await effective vaccines and therapeutics. Each of them has the opportunity to help address the challenges we're facing. Back at the beginning of the summer, end of spring, we started thinking about, okay, well, what happens when we get an effective vaccine, as all of us very much hope we will sometime soon. what is the strategy for prioritizing vaccine distribution when in the initial phases there will be a limited vaccine supply? Now, we understand that there's been ongoing manufacturing of vaccine with the hope that there will be an effective one, and that we will not be starting off with just a tiny amount of available vaccine, but some to distribute to at least some fraction of the population when the vaccine is approved, but it still will be a limited supply. So how do we best distribute it? Here we use a modeling approach. So we use a model for SARS-CoV-2 that is the traditional susceptible, exposed, infected, and recovered, a compartmental model. In this model, everyone's the same, so we need a little bit more structure. So we add to this age structure, and this is a stratified compartmental model in which we have age structure that's informed by the interactions among individuals. So these are from social contact and mixing pattern studies. We can see, for example, that most people tend to interact with those around their age, with strong diagonals that are offset by about 30 years for parents and children, and that these types of interactions may vary by country, by demography. So these kinds of age stratified models allow us to ask more targeted questions. This is, of course, very important for a disease like COVID-19, because the infection fatality ratio really varies by age. In this study reported in medRxiv recently, it's a meta-analysis of studies looking at the infection fatality ratio. And we see that there is an increase exponentially with age. So this logarithmic scale from very low infection fatality rates in those who are young to very high infection fatality ratios in those who are older. And this is the kind of data we want to incorporate in these models to inform how best to distribute the vaccine. So again, our known is that the vaccine will initially be scarce. There are a number of unknowns. So the safety of vaccines, who is the vaccine actually approved for, its effectiveness, of course, this is what the trials are for, the age-related effects. Does the vaccine work equally well across all ages? We know some vaccines, for example, are not as highly effective in older age groups. And then what are the vaccine properties? Does it just block symptoms, or does it additionally block transmission? And then the variables that we consider here include demographics and age contact structure, as I've mentioned. We can also incorporate seroprevalence with the idea that you may want to prioritize vaccination for those who are serum negative. But this is an issue that I'll leave aside, at least for this talk, and I'll direct you again to the medRxiv paper if you are interested in more of the information on seroprevalence. So we looked at prioritizing vaccination by age groups. We looked at vaccinating those under 20, those 20 to 49, those adults greater than 20, those adults greater than 60 years old, and all ages. Here looking again at the demography for the US. We evaluated what the reduction in deaths would be for vaccines of efficacy from 100% down to 50%, where 50% is the floor. That is the limit of what the FDA has said it would approve as a vaccine. And we looked at trying to reduce mortality as well as the number of infections. What we found was that for each of these scenarios, targeting adults greater than the age of 60 really is the best way to reduce mortality, whereas at least in the initial phases, when there is a limited vaccine supply, each of these seems to work about equally well for reducing infections. What about variation in efficacy by age? So we can think about baseline vaccine efficacy and then have some hinge age where we would then see a decline in vaccine efficacy. Here we plot this as this age-dependent reduction in vaccine efficacy in dotted lines. And even in this circumstance, we see that this favors targeting the elderly population. And I say the elderly, but really this is prioritizing those, not only elderly, but those with other comorbidities that render them into high risk categories. So prioritizing this population to reduce deaths is robust to variations in efficacy by age, as we went over, and also vaccine that protect only against symptoms and death with no impact on transmissibility or transmission. It is also robust to demography. So we looked at the impact under different population structures and interactions. So Belgium, US, India, Spain, Zimbabwe, and Brazil. And also as to whether the vaccine is all or nothing, meaning it either protects you or it doesn't, or as compared to leaky, where there may be some level of protection. So our current model includes contact patterns by age, demographics, susceptibility by age. I've skipped a discussion of serology, but again, direct you to our medRxiv manuscript in case you're interested, as well as age variation in vaccine effectiveness and infection fatality ratio that varies by age. This framework enables sensitivity testing. We're now investigating what happens if we adjust the reproductive number, which again it takes into account the nature of interactions among individuals. So we might imagine that people will maintain some type of social distancing and perhaps even lockdown until the vaccine is distributed across the population. Or you might imagine that individuals will say, now that we have a vaccine, we're going to resume contact as before. Those will yield two different answers. We're currently working through those and also trying to incorporate the timing of vaccine rollout, assuming it's not instantaneous, but actually something that might take a considerable amount of time to distribute to the whole population. So that work is ongoing, and we hope to have more of it soon. But we hope that this type of modeling will be useful to decision makers and also in terms of transparency and how to best distribute and prioritize vaccine for the general population. I should acknowledge, of course, that in most of the recommendations that have been cited to date for how to distribute vaccine, essential workers, healthcare workers would come first. And then there would be the consideration for how to distribute the remainder of the initial supply of vaccines to the general population. And that really is the question that we're focusing on here. Now, there have also been innovations in thinking about how to use new tools in trying to reduce the spread of SARS-CoV-2. In work that I think has been of increased discussion in the community, there's consideration of how to use low analytic sensitivity tests as compared to those with high analytic sensitivity like PCR. And this is work where the theoretical work was done by Dan Larimore and colleagues, including Mike Minna here at the School of Public Health and Ward Parker. Both Dan and Roy are at the University of Colorado Boulder. What they looked at in the theoretical work is a theoretical trajectory for SARS-CoV-2 infection. So we'd have this proliferation phase where after the virus becomes detectable, it reaches some kind of peak where the body then controls the infection and starts clearing it. So you have this proliferation phase and a clearance phase. And they look at the impact of different tests with different sensitivities on screening and surveillance strategies. And in this New England Journal paper or perspective piece, they make the argument that given that people are primarily infectious when they have a high viral load, low analytic sensitivity, cheap tests that can be applied repeatedly, so with high frequency, may actually be sufficient for stopping transmission in communities. So really making an argument for using these rapid, cheap tests with high turnaround and quick turnaround times to help as a strategy to control outbreaks. Now, these data, I should say, are, again, theoretical. One of the reasons is that most cases of SARS-CoV-2 infection are found either at or after the peak of infection. And so we've really lacked the data on what happens in this proliferation phase. Now, in some recent work, we've been able to characterize what that proliferation phase looks like. So we've been fortunate to work in a wonderful collaboration with colleagues at the National Basketball Association, where they've been using quantitative prospective longitudinal testing. And this really has enabled us to estimate the full viral trajectory. So the workflow here is that clinical samples were taken regularly and again longitudinally. They were tested by quantitative PCR so that we had CT values for each individual. And here are 3 sample trajectories where people would go from being negative to being detectable. They'd follow some trajectory and then would become negative again. So we see here the proliferation phase and then clearance. And sometimes people would have positives out here in what we would call the persistence phase. This is where people may continue shedding viral RNA, if not virus particles. Having these raw data, we can then fit to models and start to estimate what is the pace of the proliferation phase, what is the peak CT value, and then what is the trajectory of the clearance phase. So we had data from 68 individuals, 46 with acute infections, 13 of whom reported symptoms. When we then model the trajectories, we get this as our result. So we can see that those with symptoms reported and those for whom there were no symptoms reported followed similar trajectories on the way up. And those with symptoms reported took a little bit longer to clear back down to an undetectable CT value. Having quantitative CT value information, I think, can really start to, again, add to the sophistication of our clinical and public health algorithms for decision making. So with just slight increases in types of information, like actually reporting CT values, we can start to, I think, gain substantially in our decision making. For example, now having this information on trajectory, we can see that a CT value can do a pretty good job under many circumstances of describing whether someone is in an acute infection stage as opposed to in the persistence phase. You know, 2 very different answers from clinical and public health perspectives. Similarly, with 2 tests within a 2-day window, we can start to learn if the CT value indicates an increase in viral load as opposed to a decrease in viral load. Where are we in this trajectory? Are we in the clearance phase, or are we in the proliferation phase? So that information as well, very useful for making decisions about the nature of contacts, what to do with those contacts in terms of quarantine, and what to expect for the trajectory for those infected individuals. So again, information that from PCR, for example, is already present with that CT value, we can really start to make more nuanced and I think informed decisions clinically and for public health purposes. There are many, many other applications of having this trajectory information. I think we're going to see it used in all sorts of situations, from designing trials to assess the impact of therapeutics to making more informed decisions on screening populations. So with that, I'd like to acknowledge all of my colleagues and collaborators on this work. And here are a number of the citations in case you are interested in learning more. And with that, I'll stop, and I look forward to the roundtable and additional discussion.